continuous glucose monitoring. So that's all I have.
Great, thank you. Okay, next is, I guess, the meat and potatoes. The LAI and ODT second generation antipsychotics discussion. First, we have a presentation from University of Utah DDRC, I believe.
Hi, good morning, thank you. Let me get the presentation up and going here. Tell me when you're able to see those slides.
Yep, we can see them.
Okay, great. So today we'll continue reviewing the second generation antipsychotics, particularly the long-acting injectable and oral disintegrating products. I will review prescribing information, some clinical advantages, and guideline recommendations regarding these formulations. This table shows the LAIs we are reviewing in bold with their active ingredient in the left column. They are approved for use in adults, and each are indicated for the treatment of schizophrenia. Two have additional approval for bipolar 1 maintenance therapy, and one is approved for schizoaffective disorder. All are intramuscular injections except the newer risperidone product, Perseris, which is a subcutaneous injection. But regardless of IM or sub-Q route, an important point is that they all are to be administered directly by a healthcare provider. This helps ensure adequate reconstitution and mixing procedures, along with aseptic technique and proper injection. Administration by the provider also curtails intentional or accidental overdose with the product by the patient. It also allows more oversight of the patient's antipsychotic exposure. As far as the PDL placement, all of the products have preferred status except one, which is Risperdal Consta. And these agents are all reserved for patients 18 years of age or older. Before initiating an LAI, patients who are naive to its active ingredient should establish tolerability to the corresponding oral antipsychotic. For Invega Sustenna, which contains paliperidone, tolerance to risperidone is also acceptable. Invega Trinza should specifically be preceded by at least 4 months of adequate treatment with Invega Sustenna. Not only do products differ by approved indication and dosing intervals, products can also be differentiated based on the need for oral supplementation during the initiation phase. Some products are initiated with a loading dose, while others might require oral antipsychotic overlap during the initiation phase. There are two options for initiating Aristada. One is with the Aristada Initio product that serves as a one-time loading dose, and the other option without the Initio product entails 21 days of overlap with oral aripiprazole. In the event of a late or missed dose, oral supplementation with the corresponding oral antipsychotic may also be required with some of these agents. Oh, I went one slide too far. Let me get back. Here we go. So recommended maintenance dosing is either based on corresponding target oral antipsychotic doses or based on a general dosage range respective to the indication. Regarding switching between LAIs, specific instruction in labeling is lacking for the majority of products, but labeling for the Invega Sustenna product suggests that a patient can switch from a different LAI at steady state at the next scheduled dose of the previous LAI. There were no particular guidelines found that specify how to switch between each LAI product, but when considering this option, providers may develop a patient-specific approach for switching while considering unique pharmacokinetics between agents and other clinical factors. LAI formulations can help providers address adherence issues with oral therapy. Patients may prefer this formulation And it may be more suitable for a patient who is ambivalent toward taking a daily medication or who has neurocognitive or motor function issues that make a daily pill too challenging. There is greater transparency in the patient's level of adherence while on an LAI, since it is obvious to the prescriber when the patient has missed their appointment for the medication's administration. This objective adherence information can make it easier for a prescriber to determine the reason for insufficient response to therapy, whether it is non-adherence or treatment refractoriness as the cause for symptoms or relapse. Additionally, LAI antipsychotic use has been associated with reduced risk of hospitalization and mortality based on observational studies in patients with schizophrenia. A unique requirement with the Zyprexa Rilprav product that can affect the practicality of using the medication depending on the patient or the clinic is that the patient must be monitored in the clinic for 3 hours following its administration due to the risk of post-injection delirium sedation syndrome with that agent. Oh boy, let me go back a couple of slides. There we go. So regarding treatment guidelines for the management of schizophrenia in adults, the APA suggests LAI antipsychotics for patients if they prefer such formulation or if the patient has a history of poor or uncertain adherence. This includes patients with insufficient response to oral therapy and patients at risk of poor adherence, such as those with limited ability to grasp their condition or the benefits of a medication, or patients with co-occurring substance use disorder. Similar recommendations in favor of LAIs to improve adherence are provided in guidelines for the maintenance treatment of bipolar disorder. Ultimately, LAI antipsychotics can be considered for initial maintenance therapy of these disorders after establishing tolerability to the active ingredient. Their safety and efficacy, however, have not been established in the pediatric population. The labeling for Invega Trinza actually specifically recommends against its use in the pediatric population due to higher potential of adverse events. A 2017 systematic review reported only open-label, non-controlled studies and case reports available that address LAI antipsychotic use in pediatric patients. This low-strength evidence suggests that these agents may improve adherence and clinical outcomes for children with bipolar and schizophrenia disorders, but the benefits on a population level need to be confirmed by more robust studies. Professional opinion from the Florida Center for Behavioral Health Improvement and Solutions Group advises that LAIs can be considered for pediatric patients with schizophrenia as a third-line option when patients have failed at least 2 antipsychotics approved for use in this population. Due to insufficient data supporting LAI use in pediatrics, in 2013, the American Academy of Child and Adolescent Psychiatry recommended that LAIs be reserved to adolescents with schizophrenia who have chronic psychotic symptoms and a history of poor adherence. So switching gears to the orally disintegrating products, there are 4 ODT second generation antipsychotics available. These formulations were developed to increase usability in patients with difficulty swallowing tablets. They have the same indications as their conventional tablet counterpart, but are faster dissolving once placed on the tongue, usually dissolved within 1 minute, and the contents can then be swallowed without liquid. Most are with non-preferred status on the PDL, with the exception of generic olanzapine ODT that is the preferred product. Guidelines propose considering ODT antipsychotics when patients have trouble swallowing or if they are unable to swallow pills, or for patients who will not consistently swallow pills. Aside from the ODTs, though, other dosage forms could be considered for these issues, such as oral solutions or even the injectable products if they're appropriate at that point for the patient. And also depending on the availability and if that formulation ultimately meets the patient's needs. The ODT formulation may also help circumvent cheeking of the medication. And retrospective open label studies have reported some improved outcomes using an ODT for patients who were non-adherent to the conventional tablet. And they also suggest this may be related to better adherence and acceptability of the ODT product. So overall, these special formulations may be selected for patients to help mitigate some adherence issues. Before starting an LAI antipsychotic, however, tolerance should be demonstrated to the corresponding active ingredient. There are unique requirements per product. For example, Invega Trinza should be preceded by at least 4 months of Invega Sustaina therapy. And you might consider that there are a variety of scenarios in which oral antipsychotic supplementation may be needed while a patient is on an LAI medication, such as during the initiation phase, after a missed dose, maybe to address a drug interaction, or during symptom exacerbation. The LAI agents must be administered by the healthcare provider, so maintaining a mechanism such as direct dispensing to the provider will help ensure that these agents are administered properly while also contributing to the provider's awareness of the patient's adherence patterns. And finally, you may consider whether prior authorization criteria is reasonable for certain scenarios. And I'll go ahead and finish with that.
Thanks, Valerie. Okay, any questions? Okay, and then I guess the next is committee action. Is there a prior authorization form we're reviewing today or no?
Dr. Smith, it looked like there is a public comment.
Okay, yeah, let's take public comment then.
Yeah, from Dr. Rodriguez with Indivior.
Great, thanks.
Hello, good morning, everybody. Can you guys hear me?
Yep.
Great. Yeah, my name is Gibby Rodriguez. I'm a pharmacist with Indivior. I do support Perseris, which is indicated, which is long-acting risperidone indicated for schizophrenia population. Really just here for any supportive questions that you guys might have, if there was any changes with Perseris, if there's any extra information needed. But if not, I can give back my time.
Okay. Thank you. Questions? Okay, hearing none. Okay, now are we looking at prior authorization criteria or?
We don't have proposed prior authorization criteria for the antipsychotics, although I do think it's worth mentioning the controls that are currently on the long-acting injectables are controlled by age edits. So if their labeling does not indicate them for children, then the age edits are in place in order to limit them to 18 and older. And so if a claim were to come in for an individual under the established age edit, it would hit a prior authorization requirement. Also, there are also not in place at this point in time edits around use of an oral agent prior to getting an injectable agent. So kind of a step therapy edit where there are some agents that recommend an oral period with the oral agent prior to initiating the injectable formulation. And we do not have those established at this time. The other piece, oh, I see. We also, in our policy, require that long-acting injectables be dispensed directly to the provider and not to the patient, but we don't have an edit in place that actually enforces this. So they can be filled both through the point of sale pharmacy and should be then, delivered to the provider, or through our medical side as well. So, and then the last piece is there are several oral disintegrating tablets available as a preferred on the preferred side for the oral disintegrating tablets. So there are some formulations that are available.
Okay. Question about the second item, which is the dispensing piece of it. My understanding is that there was a change in the law of the last couple years that would allow pharmacies to administer the long-acting injectables. Are there pharmacies doing this?
I'm unaware if there are pharmacies that are doing that.
Okay.
I do know that at least in rural areas in Missouri, pharmacists do administer long-acting injectable medications, and it has been quite successful. Where I live up in Box Elder County, I am considered right now, other than Bear River Mental Health, the only psychiatrist in the entire county, and I do not have a private practice. So individuals either have to drive up to Cache County or south to Logan, or I'm sorry, south to Weber, or further south to even see a provider or obtain that injection. And it can be, depending on the product, every 2 to 4 weeks or longer, depending on product.
Okay. Well, maybe we should leave that one be then. I don't know. Can I ask about the part about children? So if it's outside of the age, it goes to it requires a prior authorization. What do they look for to decide whether to approve it or not? I mean, is it basically the stuff in the presentation about the adherence concerns?
Yeah, I'll take a stab at this.
Yeah.
And staff, you can back me up here if I'm missing anything. But anytime we have an injectable antipsychotic prescribed for a child, we evaluate those on a case-by-case basis and refer to our consultant. So Dr. Craig Hummel serves as an adult psychiatry consultant for Medicaid, and we interact with UPOP also for their child psychiatry staff and their experts to assist us in some of these more challenging cases, and especially where the prescribing is outside recommended standards. And so, and typically UPOP has been our go-to for all of our foster children because of their work with fostering healthy children. But we're establishing right now an agreement so that they can also provide consultant services for our non-foster children as well. And they've been gracious, and Dr. Gargaro's on the call here, and they've been gracious in assisting us from time to time with some of these cases and providing expertise in the pediatric population. So, and the criteria, I mean, maybe Dr. Gargaro, you want to speak to how we work up those cases, or maybe Dr. Hummel.
Yeah, one thing that I was noticing based on the presentation is I'm wondering if in our review of prior auths for kids on long-acting injectables, if there should be a criteria of they've had to try and fail an ODT formulation prior to the LAI based on what we just saw in terms of guidelines.
That sounds good. I agree. That'd be beneficial. Any other comments or questions?
Stop that.
It looks like Dr. Weinstein has raised her hand.
Let's see. Yes, thank you. This was just a comment about off-label use in pain medicine and palliative care, we do have clinical literature support for sublingual for olanzapine in headache and in palliative care for multiple symptom. And in that case, often we would be using the sublingual formulation. I don't think this is going to be a high volume, and I don't know that it necessarily needs a provision, but I just wanted to submit that comment that that might be seen at times, given that there may be some practitioners who are aware of that and may find use.
Dr. Weinstein, is that for? This is Joe from Medicaid Pharmacy. Is that for all ages?
I've generally seen it in adults. I mean, I do some pediatric palliative care, and I don't think most folks in pediatric palliative care, particularly out of IHC, I don't see that they're going to be using it much. I think this is mostly going to apply to adults.
Thank you.
The literature is in adults. Yeah, the literature is in adults. Yeah.
Thank you. And Dr. Gonzalez, Valerie, there's a widespread perception among the provider community that ODTs have faster onset of action. Can you speak to that? We get a number of requests for these medicines just for that specific use.
Yeah, I tried to look into that a little bit. Like, the closest thing that I could come to finding something about that was more related to the Tmax. I have seen pharmacokinetic studies that graph the concentration curve, and you can see that the Tmaxes between the ODT and the conventional tablet, they're pretty similar. So there's really not much information I've seen that says the Tmaxes occur at any significant, difference of time. And there's really no studies I saw that actually look at the onset of effect, or even how quickly the drugs show up in the bloodstream. You could kind of see it on the concentration curves, but you'd be just like roughly visually comparing those graphs, and there's nothing that I saw to map out the onset of action and how that actually looks as far as outcomes. So I suspect if clinicians feel this way, it's more of, based on their experience, maybe, especially maybe those that are treating really acute, like psychotic exacerbations. Maybe they're the ones that, have that perception based on what they have seen in their patients. So I didn't see any substantial, evidence or studies looking at that.
Well, we do know in our pain studies comparing, transmucosal to intravenous and oral, we've got that literature, and so I'm not sure that the minutes versus 15 minutes versus 30 in using these drugs in the treatment of psychosis would be significant. In our pain literature, it might be significant, but what I think is most clinically relevant in using an oral dissolving tablet in our symptom management is for people who are nauseated and vomiting, and they can't manage an oral tablet. So, or for the treatment of headache where vomiting is an associated symptom, then, that's where we found it in the headache literature, and particularly for people who have primary migraine, that's often the symptom complex. So that's where that alternate route of administration becomes favorable. But for onset and peak to symptom relief, there might be some differences in terms of minutes, within 15 minutes versus 30, for a typical oral administration without a full stomach. But I'm not sure that that's clinically relevant. And I'm speaking again just from clinical experience and what we know from our pain literature, where I have done research on transmucosal formulations. So I'm just extrapolating that, and also from having used these sublingual products over decades.
Thank you.
Like we have
Thank you. That
question
helps us as we do.
I think we have a question from somebody in attendance, Craig Hummel.
Yes. I've seen the oral dissolving used in a couple of places. One is acute agitation in adolescents. I'm not saying that's proper or not, but we've had requests for that. And when you do a peer-to-peer with the provider, it seems to make sense. It's usually with olanzapine because of sedating, and the alternative is to either give them olanzapine IM, which is usually troublesome because a lot of times these kids are in residential care, or they're going to have to go with Haldol, which has a lot more side effects. So that's one place I see it used in children. And also in some of my cohorts helped me out that I think we've seen kind of a cocktail in kids with leukemia because they're nauseated, and they use olanzapine, and I forget the other concoction that they use with that. So I'll shut up.
And that's correct, Craig. It is listed in the NCCN Oncology Anti-Emesis guidelines.
Right.
Thank you for reminding us of that.
That's our palliative care literature, and there's good support there.
Great.
I would say, having quite a bit of experience on adult and inpatient psychiatric units, that it depends really on whether or not the pharmacy at that facility has orally disintegrating tablets versus a solution. Because we always try to offer someone, before they escalate to the point where they might need an injection, either an orally disintegrating tablet or a solution or some liquid form of a second generation antipsychotic. But it depends in part on availability at the individual community hospital level. I think that a lot of the perception that it works faster, may depend on whether the person is in the fasting state or not, and sort of also the presentation of the individual and what the indication is. I don't think it would be something that you would routinely give to someone unless they had some neurodevelopmental issue with swallowing or some other mechanical or other issue that would, require an orally disintegrating tablet, or, versus say a liquid or something of that.
But thank you, Dr. Seifried. It's very common for us to get prioritization requests for, as Craig mentioned, olanzapine orally dissolving tablets on a PRN basis, and they might use, say, 15 a month, and we struggle with whether that's reasonable or not. I welcome guidance from any other committee member.
I think that sort of depends to the population. In general, for kids, I know, speaking more from our foster care literature and things along those lines, there's really a big push that PRNs such as olanzapine really should be in an inpatient setting versus, in the outpatient community. That being said, if somebody is getting a PRN, I could see there being the argument of the cheeking or the agitation, and thus, rather than the onset of action, the reliability of the administration of the medication as potentially being a reason to favor the ODT. But again, I think it seems like from what Dr. Gonzalez presented that, really as we go along the line from your tablet to your ODT to your long-acting injectable, that it is almost that continuum of, if the oral formulation isn't effective or there's adherence issues, then maybe the ODT. And then if that continues for folks that have an indication for long-standing antipsychotics, then that LAI potentially for the pediatric population, plus minus that ODT for the adult population, it sounded like.
Thank you.
Now, in the adult population, if this is just being given to the patient themselves to take PRN, then you really need to examine the patient's regimen and their compliance. If the patient is member is in a facility where it is being administered by someone else, it makes more sense. But using it and just dispensing it to the patient, or just as a PRN medication with no oversight in terms of dispensing it, is really not an indication for using it even on a PRN basis.
Thank you, because we get those requests.
Hey, Joe, this is Kyle. Can you hear me okay?
Yep, we hear you.
Hey, are those requests coming from a mental health perspective, or do you suspect maybe some of those requests are sort of off-label because our physicians will use olanzapine PRN for breakthrough nausea vomiting on cancer regimens?
So Kyle, thank you for that question. For the latter, for anti-emesis, we approve almost all of those routinely. Obviously not if they're, very young child being treated for something. But so no, it was more the mental health use. And as Dr. Siegfried and Dr. Grauer point out, while we do see some for our patients that are in residential facilities, we get a number of requests on an outpatient basis. And I should be fair, many of them are for developmentally disabled kids. And as Dr. Hummel pointed out in past discussions, we routinely approve those too. But, which seem to make sense. Some of those kids are profoundly challenged, and this is helpful. But for adults, we get requests for PRN, ODT, or it doesn't matter. There's 4 or 5 of them, and we struggle with the rationale behind that. So we appreciate the guidance of the committee. Thank you, Kyle.
Yeah, that makes sense. Thank you.
And you haven't seen many PRN for headache, I take?
No.
Great. Any other comments or questions? Okay. How are we proceeding from here? Are we looking at addressing more officially prior auth in the future, or is this kind of more for helping the state kind of manage things that come up on kind of more limited basis?
I do have a question. I know that these agents have their warnings, and I've used these, not so much in the primary psychiatric indication, but fairly extensively in my clinical zone. with their proper use, do we think they're high risk medications in terms of the kinds of adverse events reports that you see, or do you think the warnings are sufficient and the people following the dosing guidelines? Are these relatively safe in this expert panel's opinion?
I would say first that unfortunately both clozapine and long-acting injectable antipsychotics are underutilized in most psychiatric populations, although there's also some evidence that they have been overutilized in certain ethnic groups. The only long-acting injectable for which there is more concern is the Zyprexa Relprevv, because it does have the black box warning with the risk of the delirium sedation syndrome, and this can occur at any point in treatment. So it is not something that would just occur with potentially, thinking about most adverse effects with the initiation of treatment or change in dose, and requires 3 hours of on eyes observation. It is not where you sit in the waiting room and the person who's checking patients in at the front desk is supposed to be watching them. You literally are, according to the REMS, supposed to have someone specifically watching this individual. And in chronic mental illness, it's also very hard to have people who often will smoke cigarettes or who do get side effects such as restlessness or akathisia have to sit and not move around for that 3 hour period of time. And it can be administered as frequently as every 2 weeks. I really struggled when I was at the VA with even approving this product to be used in majority of patients for those reasons. It's very costly in terms of time, and it really is more difficult, I think, in terms of gaining compliance. With regards to the other long-acting injectables, for the most part, individuals who are using them generally are able and have experience in using them, and they're otherwise equally fairly safe and efficacious. Although the first generation drugs obviously had more side effects, more pain with injection.
But Dr. Weinstein, good question, and I defer to Dr. Gonzalez for her review of the literature. But I think while the second generation are thought to be a little more safe, they still are concerning medicines, which is why, as we adjudicate these, particularly for children, we try to get Dr. Grigaro's help or whoever else, get expert guidance, because they are certainly not innocuous.
All right. Good discussion here. Okay, so are we moving on to the next item on our agenda then? Trodelvy? Does that work? Okay. Do we have are we looking at a prior authorization on that one? Or is there a presentation?
Yes, I have the presentation, as I have the prior authorization up.
Thank you.
Yes. So this is the prior authorization for Trodelvy. Utah Medicaid have vested this with the expert in the cancer field. And this is some of the criteria that we develop. For the criteria for approval, all of the following criteria must be met: the diagnosis of metastatic triple negative breast cancer, use of at least 2 prior therapy for metastatic disease. We require the provider to list the medication, the dose, the detail of therapy, and documented that in the submitted chart note. Trodelvy will not be used with other drug containing irinotecan or its active metabolite SN30A. Provider must provide a plan to monitoring absolute neutrophil count for count below 1500 or neutropenic fever as baseline and periodically during the treatment. Those have to be mentioned and in the chart note. We have re-auth criteria is updated letter of medical necessity or updated chart note demonstrating positive clinical response. Initial authorization will be up to 6 months and re-auth will be up to 1 year after.
Great. Any comments or questions? So this is a brand new prior authorization, is that correct?
This is the updated prior
Updated.
authorization. Yeah.
Okay.
This is Kyle. Just having gone through this, I really feel like this follows the prescribing information pretty much exactly, and I feel like this authorization is appropriate and follows how you would expect this product to be used, at least at this point in time, since it's so new. And I mean, a very good option, but I think it's completely appropriate. This is kind of the direction it should be used in. That's how I feel.
Great. Thank you. Any other comments or questions? Okay, so maybe we need and we have no public comment on this one, is that correct?
Sorry, no, we don't have public comment on this.
You said we do not?
We do not.
Okay, thanks. A little bit of a delay there. All right, so is there a motion to approve?
Yeah,
So
I'll
moved.
motion to approve.
Okay, I'll second to Eric.
Okay, thanks. All right, all in favor of approving this, say aye.
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 Any opposed? Abstentions? Okay, thank you. That has been approved. Going back to our agenda, we don't have any other agenda items. Is there anything that we left out?
That should be all in the agenda today.
Okay, great. All right, is there a motion to adjourn in that case?
I'll move to adjourn.
Thank you. Second?
Second.
Okay, all in favor, say aye.
Aye. Aye.
Aye.
All right, thank you, everyone.
Happy New Year.
Happy New Year. See you next month.